Hello, my name is Andreas Duma. I'm from the Department of Anesthesia and Intensive Care Medicine, Medical University of Vienna, Austria, and I will talk to you about the current place of vasopressin. Thanks for having me. Conflicts of interest, I received support from Amomed and Roche Diagnostics within the last 3 years. Decatecholamines during sepsis, this is one of the concepts why you should use vasopressin and not only norepinephrine when you support your patients in vasodilatory shock. The downside of higher dose NOR can be myocardial injury, arrhythmia, impaired immune response, impaired splanchnic function, coagulopathy, microcirculation, and several others, as you see here on this nice figure. That's why you should use vasopressin. Vasopressin has the effect on blood pressure via V receptors. It leads to vasoconstriction and raising blood pressure, as well as vasoconstriction in the kidney to increase diuresis, and also recruits aquaporin via V receptors and increases water reabsorption and preserving volume. So these are the physiological effects that led to testing vasopressin now for more than 20 years in shock for its use. So what types of shocks vasopressin may be used? So definitely the most prominent research that has been going on so far for septic shock, but also another form of distributive shock, vasoplegic shock after cardiac surgery. So this is what I will tell you most about. And just to see that there are also some niches in other parts of shock, other types. I'll let you know some about cardiogenic shock, hemorrhagic shock, and possible place of vasopressin there. So in septic shock, 3 major RCTs were published: the VAST, the VANISH, and VANCS 2 trial. VAST randomized 800 patients on norepi to receive vasopressin or norepi. Low-dose vasopressin was used. However, primary outcome was negative, but in the safety, no difference in side effects was seen. So subgroup and post-hoc analysis of the VAST trial revealed that subgroups had beneficial effects with the use of vasopressin. So patients with less severe shock, they had significantly less mortality, and also patients with renal risk had a lower rate to progression to renal failure or loss, and the use of renal replacement therapy. So these subgroup analysis led to the VANISH trial, where vasopressin versus norepi was tested as a first-choice vasoconstrictor. It was given earlier than in the VAST trial. It was given also at higher doses, and it looked at primary outcome at kidney failure-free days. However, it was negative, so there were no differences in that. However, of note, safety, again, no difference in side effects with the use of vasopressin. VANCS 2, 250 cancer patients in septic shock. This was released last year in December. The most recent study, RCT in septic shock. Cancer patients have a especially high mortality in septic shock and are an increasing population. However, unfortunately, also here, primary outcome did not change with the use of vasopressin, so it was not superior to norepinephrine. In terms of safety, there was no difference in side effects looking at the results of this trial. So what about pooling all these 3 studies? Is there any benefit? Yes, there is, even though not on mortality. but on arrhythmias. So there is fewer arrhythmias with a risk difference minus 2.8%. On the other side, you have more digital ischemias with the use of vasopressin. Just to know, these digital ischemias were not severe adverse events. They did not lead to amputation or long-term disabilities. So the current place of vasopressin in shock in the most prominent recommendations is that there is the recommendation to add vasopressin to norepi or epi with the intent of raising MAP to target or to decrease norepi dosage. So this is the concept of decatecholamines, and we're seeing benefits in subgroup of patients by analyzing these trials that were published in the last 12 years. So in distributive shock, there is the VANCS trial that is most prominent in vasoplegic patients after cardiac surgery. Primary outcome was positive in this study. As you can see, mortality or severe complications were much higher in the group that received norepi versus those who got treated with vasopressin, 32 versus 49%. Secondary outcome, atrial fibrillation, also part with the concept of decatecholamines. AFib was less with the use of vasopressin versus norepi. So meta-analysis pop up every month with the topic of vasopressin and efficacy, safety. So I want to show you quickly some of the most important published in the last years. Benefits versus risks. So in cardiac surgery beyond shock, so this is not in shock, it's in all kind of cardiac surgery patients, it was of benefit. It reduced the pooled OR of perioperative complications. As you can see, this is basically a pool of all kind of complications you may think of in this population. However, prospective trials are needed to further elucidate the benefit in for different kinds of complications and the extent of benefit. A very prominent study by McIntyre published in JAMA pooled the studies for all studies with distributive shock, so septic shock, and those after cardiac surgery, and found less AFib. This is also really an argument to use vasopressin because AFib also confers complications such as stroke and mortality. On the other side, and this is basically with most or almost all meta-analysis, again, more digital ischemia in this meta-analysis. Adverse events and effects in another meta-analysis showed a slight reduction in mortality in this publication by Jiang in Critical Care 2019, and again, more digital ischemia. So the Canadian Critical Care Society recommends not only in septic shock, but also in all forms of distributive shock, the use of vasopressin, because they argued that it has a slight reduction of mortality in the pooled analysis of 18 RCTs they did recently, and a reduced risk of AFib, and that outweighs the increased risk of digital ischemia. So short notice on cardiogenic shock. In cardiogenic shock, primarily you don't want to use vasopressin because you often want to use inotropes. However, during right ventricular failure or aortic stenosis, where afterload where you have an afterload dependent state, it may be advocated to use vasopressin, especially because it does not increase pulmonary arterial pressure. So this is really the benefit for states with a stressed right ventricle to use additional vasopressin. In hemorrhagic shock and trauma patients, a recent study showed that in patients who got 6 units of blood, vasopressin or placebo for the following 48 hours reduced significantly the use of blood products by 1.4 liters. So patients got included when they got 6 units of blood, then they got a push of 4 units of vasopressin, push dose, and then continuous infusion or placebo, and total volume of blood transfusion was the primary outcome. It may safely decrease the need for blood products. For sure, future series of trials will further test these results and see if they are applicable. So in summary, the current place of vasopressin, it's recommended by the Surviving Sepsis campaign to add it to norepinephrine with the intent to raise them up. And it also shows in meta-analysis a reduction rate of perioperative complications in cardiac surgery. Especially the rate of AFib seems to be reduced with the use of vasopressin. In cardiogenic shock with right ventricular failure, patient-tailored use may be good, and in trauma, low-dose vasopressin may safely decrease the need for blood products. Thank you.